How to avoid a dangerous blood clot, symptoms, flights, and There is a clot forming in someone's leg right now, at this exact moment, and they have absolutely no idea. No pain yet, no swelling yet, nothing that feels like anything other than a normal day. And within the next 48 to 72 hours, a piece of that clot will break off, travel through their venous system, pass through the right side of their heart, and lodge in the blood vessels supplying their lungs. That is a pulmonary embolism. And depending on the size of that clot fragment, it will either send them to the emergency room in serious distress, or it will kill them before they get there. I am not saying that to frighten you. I am saying it because it is exactly what I see, and because the tragedy of it every single time is that it was preventable. The risk factors were there, the warning signs were there, the window to intervene was there, and nobody acted on any of it. Hi, I'm Dr. James Whitfield. I'm an emergency medicine physician, and I have spent just over a decade working in the ER. In that time, I have personally treated more than 40,000 patients. Blood clots, deep vein thromboses, and pulmonary embolisms are among the most common life-threatening emergencies I manage, and they are also among the most consistently misunderstood conditions in medicine. My whole mission with this channel is to make sure you never need to come through those ER doors for something that was building quietly for days or weeks while feeling like almost nothing. So here is exactly what we are covering today. I am going to walk you through the critical things you need to know about dangerous blood clots, how they form, how to recognize the symptoms before they become an emergency, what flying actually does to your clotting risk and why, what other triggers most people are completely unaware of, and the practical evidence-based steps you can take to protect yourself. And at the end, I will give you a clear framework for knowing when something needs same-day emergency attention versus when it is something to discuss with your primary care doctor. Before we get into it, if you are not yet subscribed, please consider doing that now. Only about a quarter of the people watching these videos have actually hit that button, and this channel only grows through people like you. I promise to keep making the most honest, clinically grounded content I possibly can. And if you get to the end and did not learn something genuinely new, you can unsubscribe with no hard feelings whatsoever. Right, let's get into this. Number 1. How a blood clot actually forms, because most people have this completely wrong. Most people think of a blood clot as something that just randomly appears, like a switch that flips without warning. The reality is beautifully precise when you understand it, and understanding the mechanism is what makes the prevention strategies make actual sense rather than just feeling like arbitrary advice. Your blood's clotting system exists for one essential reason: to seal wounds. When you cut yourself, a cascade of proteins in your blood activates within seconds, forming a temporary plug of platelets and fibrin, a structural protein, to stop you bleeding out. This system is one of the most elegant pieces of engineering in your entire body, but it has one significant vulnerability. It can be triggered not just by a wound, but by 3 other conditions. And these 3 conditions are what a 19th century German physician named Rudolf Virchow identified, and we still call them Virchow's triad today. The first is slowed or stagnant blood flow. When blood is not moving briskly through a vessel, it pools slightly. The clotting factors that are normally swept downstream before they can accumulate begin to concentrate. The second is damage or irritation to the vessel wall itself. The inner lining of your veins, the endothelium, when damaged by inflammation, surgery, trauma, or certain medications, exposes the underlying tissue to the bloodstream, and the clotting cascade reads that exposure as an injury signal. The third is a state of hypercoagulability, meaning your blood is in a condition where it clots more readily than normal, driven by genetic factors, hormonal changes, cancer, dehydration, or infection. What becomes clear when you look at almost every dangerous clot is that it involves at least 2 of these 3 factors working together. And the deep veins of the calf and thigh are the most common sight because those are precisely the vessels where blood flow slows most dramatically. When you are immobile, the vessel walls are subject to the most pressure variation, And the distance from the heart means any clotting factors that accumulate are slow to be cleared. The practical takeaway from this mechanism is that clot prevention is not mysterious. It is about addressing these three factors directly. Keep blood moving, protect vessel wall integrity, and identify if your blood has any reason to be in a hypercoagulable state. Everything else in this video flows from those three principles. Number 2, the symptoms. What a clot actually feels like, and why people miss it. Let me be really honest here, because the symptoms of a deep vein thrombosis, a clot in the leg, are genuinely easy to dismiss. And they are easy to dismiss precisely because they mimic so many less serious things. The classic presentation is a unilateral calf or thigh that becomes swollen, warm, tender, and sometimes reddened along the course of the affected vein. Unilateral means one side only. That asymmetry is one of the most important clinical clues. If both legs are equally swollen, the cause is almost always something systemic: heart function, kidney function, venous insufficiency. If one leg is noticeably more swollen than the other, particularly if it appeared over hours to days rather than weeks, a deep vein thrombosis is high on the list until proven otherwise. The tenderness tends to localize along the inner calf, and there is a clinical sign called Homan's sign, where pain is reproduced by flexing the foot upward toward the shin. I want to be clear that this sign alone is not reliable enough to diagnose or rule out a clot. We use ultrasound for that, but it is a useful thing for you to be aware of as a prompt to seek assessment rather than a diagnostic test. Now here is what people most commonly mistake a deep vein thrombosis for: a muscle strain or cramp from exercise, a pulled calf muscle, general leg fatigue after a long day of standing. In fact, there was a study published in the Annals of Emergency Medicine that found the median time between symptom onset and patients presenting to emergency care for a confirmed deep vein thrombosis was over 4 days. 4 days of dismissing it as something else. And in that 4-day window, the clot has time to propagate, to extend further up the vein, and to reach a size where fragment embolization becomes far more dangerous. For a pulmonary embolism, when a fragment has already broken off and reached the lungs, the symptoms shift. Sudden onset breathlessness that feels disproportionate to any activity. Sharp chest pain that worsens with breathing in, what we call pleuritic chest pain. A cough, sometimes with blood-streaked sputum. A feeling of profound anxiety or impending doom that patients often describe in precisely those words. A rapid heart rate. And in severe cases, lightheadedness, near fainting, or collapse. The practical takeaway: if you have a unilateral, swollen, warm, tender leg that appeared over hours to days, that is an ER or same-day urgent care visit. Do not wait to see if it improves. And if you have any combination of sudden breathlessness, pleuritic chest pain, and rapid heart rate, that is an emergency call now situation. These symptoms together have a high clinical probability of pulmonary embolism until proven otherwise. Number 3. What flying actually does to your clot risk, because the mechanism is more specific than most people realize. The association between long-haul flights and blood clots is something most people have vaguely heard of. What almost nobody understands is the precise combination of factors that makes a flight genuinely dangerous for clot formation, because it is not just about sitting still. A commercial aircraft cabin at cruising altitude is pressurized to the equivalent of approximately 6,000 to 8,000 feet above sea level. At that altitude, the partial pressure of oxygen in the cabin air is lower than at sea level. Your blood oxygen saturation drops slightly, typically by 2 to 4 percentage points in healthy individuals. This mild hypoxia, that is low oxygen, directly activates certain clotting pathways. Specifically, it upregulates tissue factor expression on the endothelial cells lining your vessels, making those vessel walls slightly more prone to triggering the clotting cascade. That is factor 1 from Virchow's triad already active. At the same time, you are sitting in a narrow seat with your knees bent, often with the seat in front pressing against your lower thighs. This position compresses the popliteal vein, which runs behind the knee, and the femoral vein in the thigh. Blood flow through those vessels slows. That is factor 2. And most people are dehydrated on flights. The cabin humidity is typically between 10 and 20%, far lower than the 40 to 60% humidity most people live in. Insensible water loss through breathing and skin evaporation is significantly higher than normal, and most people drink less water on flights than they would on the ground, often replacing it with alcohol or caffeine, both of which have additional dehydrating effects. Dehydration increases blood viscosity, meaning your blood thickens slightly and flows less freely. That pushes toward hypercoagulability, factor 3, so a long-haul flight simultaneously activates all 3 components of Virchow's triad at the same time. That is why it is a genuine risk, and not just a theoretical one. There was a study published in the British Medical Journal, a large prospective study called the Right Project, conducted in collaboration with the World Health Organization, that found the risk of a venous thromboembolism roughly doubled for every 4 hours of flight duration. For flights over 8 hours, the absolute risk in the general population remains relatively low, but in people with additional risk factors, obesity, recent surgery, oral contraceptive use, pregnancy, known thrombophilia, that relative risk elevation becomes clinically significant. The practical takeaway. On any flight over 4 hours, stand up and walk the aisle for 2 to 3 minutes at least once every 90 minutes. Do calf raises in your seat, pressing your heels down and lifting your toes, then lifting your heels. 10 repetitions every 30 minutes. Drink water consistently throughout the flight, approximately 200 milliliters per hour of flight time. Avoid alcohol and minimize caffeine. Wear compression stockings rated at 15 to 20 millimeters of mercury on any flight over 6 hours, and particularly if you have any of the additional risk factors I mentioned. If you are in a high-risk group, speak to your primary care doctor before a long-haul flight about whether a single prophylactic dose of low molecular weight heparin, a short-acting anticoagulant injection, is appropriate for you. Number 4. The risk factors most people have never been told about. Everyone knows the obvious ones: long flights, recent surgery, being bedridden. But there is a set of risk factors for clot formation that are far less discussed and far more common in everyday life, and I want to go through them because several of them probably apply to people watching this right now. The first is hormonal contraception and hormone therapy. Combined oral contraceptive pills, those containing both estrogen and progestogen, increase the risk of venous thromboembolism by a factor of roughly 3 to 4 times compared to non-users. The mechanism is that estrogen increases the liver's production of several clotting factors, tipping the coagulation balance toward the clot-forming side. The absolute risk for an individual young healthy woman is still relatively low, but the interaction with other risk factors, smoking, obesity, immobility, long-haul travel, is multiplicative rather than additive, meaning the risks compound each other rather than simply adding together. There was a study published in the British Medical Journal reviewing data from over 100,000 women that found the combination of oral contraceptive use and long-haul air travel produced a clot risk approximately 18 times higher than baseline in women with no other risk factors. 18 times. From 2 factors that most people would consider completely routine and unrelated. The second underappreciated risk factor is cancer. Active malignancy is one of the strongest independent risk factors for clot formation we know of. Tumors release procoagulant substances and inflammatory signals that shift the blood toward hypercoagulability. Certain cancers, pancreatic, lung, colorectal, and hematological malignancies in particular, carry especially high thrombotic risk. In fact, a new unprovoked deep vein thrombosis in an adult over 50 with no other clear risk factor is something we always investigate for occult malignancy, that is an undetected cancer. The third is dehydration from any cause, gastroenteritis, heat exposure, intense prolonged exercise without adequate fluid replacement, even a few days of reduced oral intake during an illness. Dehydration thickens the blood, slows flow, and increases clotting factor concentration per unit of blood volume. It is simple physics applied to fluid dynamics, and it is one of the most correctable risk factors there is. The fourth is inflammatory conditions. Conditions like inflammatory bowel disease, lupus, rheumatoid arthritis, and even severe acute infections, including certain respiratory illnesses, all produce systemic inflammatory states that directly activate endothelial cells, damage vessel walls, and shift the coagulation system toward clot formation. There was a study published in the journal Gut that found patients with active inflammatory bowel disease had a 3-fold higher risk of venous thromboembolism compared to the general population, a risk that dropped significantly during periods of disease remission. The practical takeaway: know your personal risk profile. If you are on combined hormonal contraception, if you have an active inflammatory condition, if you are going through cancer treatment, or if you have a family history of clots, these factors need to be in the room whenever you are planning any period of immobility, any surgery, any long journey, or any significant illness. Tell every clinician who treats you. These interactions are exactly the conversations that prevent the emergencies I see coming through the ER. Number 5. The genetic clotting disorders that run silently in families. This one is genuinely important and genuinely underdiagnosed. There is a group of inherited conditions, we call them thrombophilias, that make a person's blood intrinsically more prone to clotting. These are not rare exotic diseases. The most common of them, factor V Leiden mutation, is present in approximately 5% of people with European ancestry. The second most common, prothrombin gene mutation, is present in about 2 to 3%. Together, these two mutations alone mean that somewhere between 1 in 14 and 1 in 20 people of European descent carry a genetic clotting predisposition they almost certainly do not know about. These mutations do not guarantee that someone will develop a clot. What they do is shift the threshold. Under normal circumstances, the clotting system never gets triggered inappropriately, but add one of the environmental triggers we have discussed, a long flight, oral contraceptive use, a surgical procedure, an acute illness with dehydration, and the threshold for inappropriate clot formation is crossed far more easily in someone with a thrombophilia than in someone without one. What we know is that a family history is the most important clue. If a first-degree relative, a parent, sibling, or child, had a deep vein thrombosis or pulmonary embolism, particularly if it occurred before age 50 or without an obvious trigger, there is a meaningful probability that a familial thrombophilia is present. There was a study published in the Journal of Thrombosis and Hemostasis that found first-degree relatives of patients with confirmed factor V. Leiden had an approximately 5-fold higher lifetime risk of venous thromboembolism compared to the general population, 5-fold, from a mutation that a simple blood test can detect. The practical takeaway: if you have a family history of blood clots, particularly in younger relatives or in unusual sites like mesenteric veins, cerebral veins, or portal veins, ask your primary care doctor specifically about thrombophilia screening, a panel of blood tests covering the most common inherited and acquired clotting disorders takes a single blood draw. If a mutation is found, it does not necessarily require long-term treatment, but it fundamentally changes how you and your clinicians should approach periods of risk. It means prophylactic anticoagulation before major surgery. It means a serious conversation before starting hormonal contraception. It means knowing, with clarity, what situations require extra vigilance. Number 6, the prevention strategies that the evidence actually supports. Let me be really clear here, because there is a lot of folklore around clot prevention, and I want to separate what genuinely works from what is just reassuring noise. The single most evidence-supported non-pharmacological intervention for clot prevention is movement, specifically regular activation of the calf muscle pump. Your calf muscles, when they contract during walking and calf raises, squeeze the deep veins of the lower leg and physically push blood upward against gravity toward your heart. This is the primary mechanism by which venous blood returns from the legs, and without it, flow in the deep veins slows dramatically within minutes of sitting still. There was a study published in the British Journal of Surgery that used Doppler ultrasound to directly measure deep venous flow velocity in seated subjects and found that peak venous flow velocity dropped by over 50% within 30 minutes of sitting still and recovered rapidly with even brief calf muscle activation. 50% drop in 30 minutes. That is how quickly the conditions for clotting begin to develop. Compression stockings work through a complementary mechanism. By applying graduated external pressure, highest at the ankle and reducing toward the knee, they increase the velocity of venous return and reduce the diameter of the superficial veins, redirecting blood through the deeper, faster-moving venous system. There was a Cochrane review of multiple randomized controlled trials that confirmed below-knee compression stockings significantly reduced the incidence of asymptomatic deep vein thrombosis in long-haul air travelers. Hydration works by maintaining appropriate blood viscosity and flow velocity, as we discussed. The target is pale yellow urine, not clear, which can indicate overhydration and electrolyte dilution, and not dark yellow, which indicates meaningful dehydration. Aspirin is something people often ask about. The evidence for aspirin in venous clot prevention is actually modest compared to its role in arterial clot prevention, which is a different mechanism entirely. Low-dose aspirin has some benefit in specific surgical and orthopedic contexts, but it is not a reliable substitute for proper anticoagulation in high-risk situations. Do not self-prescribe aspirin as clot prevention without a clinical conversation about whether it is appropriate for your specific situation. The practical takeaway: your non-pharmacological prevention toolkit is movement every 60 to 90 minutes without exception during any prolonged immobility. Compression stockings for any flight over 4 hours or any situation of prolonged sitting, consistent hydration with water rather than alcohol or caffeine, and knowing your personal risk profile well enough to have an informed conversation with your primary care doctor before any situation that compounds your baseline risk. Now here is the framework I promised. 3 categories. Know which one you are in. Category 1. Call emergency services or go to the ER immediately. Sudden shortness of breath that appeared over minutes with no clear cause. Chest pain that worsens when you breathe in. Rapid heart rate combined with breathlessness and lightheadedness, coughing up blood, a feeling of sudden severe anxiety or doom alongside any of the above. These symptoms together represent a high clinical probability of pulmonary embolism. Time matters here in a way it truly does not for most medical conditions. The faster anticoagulation starts, the lower the risk of a fatal outcome. Category 2. Go to urgent care or the ER today, same day. A unilateral swollen, warm, tender calf or thigh that appeared over the last 1 to 3 days, particularly following a period of immobility, surgery, illness, or a long journey. Do not wait overnight. Do not see if it improves. A venous ultrasound takes minutes and gives a definitive answer. If it is a clot, treatment started today is dramatically more effective than treatment started next week. Category 3. Schedule a primary care appointment this week. You have a family history of blood clots and have never been screened for thrombophilia. You are on combined hormonal contraception and are about to have surgery or a long-haul flight. You have an active inflammatory condition, and your clot risk has never been formally discussed with your doctor. You want to understand your personal risk profile before it becomes relevant in an emergency. Here's the bigger picture I want to leave you with. Clots are one of the clearest examples in all of medicine of a condition where the window between preventable and catastrophic is both very real and very narrow. The physiology gives you signals. The risk factors are knowable. The interventions work. The problem is almost never a lack of available treatment. It is a lack of awareness at exactly the right moment. Every single day in the ER, I see the consequences of a clot that had warning signs that were dismissed, a flight that was taken without precautions, a family history that was never discussed, a risk factor that was never connected to anything until it was. And every single time, Somewhere in the history, there was a moment where a different decision would have changed everything. You now know what most people walking around right now do not know: the mechanism, the symptoms, the triggers, the genetics, the prevention. Use that knowledge. Share this video with someone who flies regularly, who is on hormonal contraception, who has a family history of clots, or who simply does not know that this is something worth understanding before it becomes urgent. And if you are not yet subscribed, please do hit that button now. Thank you genuinely for watching. Take care of yourselves. And if anything in this video prompted a concern about your own health, please act on it today rather than tomorrow.